Everyone. My name is Liz Lazo, and I would like to welcome you all to today's national webinar hosted by the AATC National Coordinating Resource Center, presented by the AATC program. Today's session is part of the HIV and COVID-19 Winter Webinar Series. Today's presenters are presenting on behalf of the Mountain West and New England AATC, Drs. Jocelyn James and Erin Mears. Dr. Jocelyn James is an assistant professor of medicine at the University of Washington in Seattle. She is an internal medicine and addiction physician and practices primary care at Harborview Medical Center and at a satellite clinic located at Evergreen Treatment Services and Opioid Treatment Program. Her clinical research and teaching interests include treatment of opioid use disorder, primary care for people with substance use disorders, and treatment of hepatitis C. She finds caring for people with substance use disorders very gratifying and is appreciative to all her past and current patients for the privilege to learn from them and partner with them in their care. Dr. Erin Mears is a clinical psychologist who has been with the Dartmouth Hitchcock HIV program since 2017. Prior to that, she worked with high-risk youth in private settings, at community mental health, and in schools. She attained her doctorate in psychology in 2015 from the California School of Professional Psychology in San Francisco. She has been trained in a variety of trauma-focused therapies, including dialectical behavioral therapy, acceptance and commitment therapy, and eye movement desensitization reprocessing, EMDR therapy. Dr. Mears has a passion for social justice and helping others. She works on a variety of committees to help make New Hampshire a better place for everyone. She enjoys teaching because knowledge is power and has a wide variety of research interests, including the intersectionality of gender identity and autism spectrum disorder, the impact of stigma and discrimination of people living with HIV, and the impact of burnout on mental health care providers. Dr. Mears loves the work that she does with Dartmouth Hitchcock HIV program and appreciates the privilege it is to provide care for her patients. Today's learning objectives will be to understand that rates of overdose deaths have increased around the country during the COVID-19 pandemic, identify 3 concrete steps providers can take to address overdose risk in people with substance use disorder, identify at least 2 risk factors for suicidal ideation in people with HIV, and identify at least 2 factors on how COVID-19 impacts the mental health of people with HIV. At this time, I would like to turn it over to Dr. James.
Thank you so much, Liz. Good morning, everyone, or good afternoon if you're farther east than I. I'm truly honored to be taking part in this webinar today and really appreciate the organizers for the invitation and for the just excellent organizing. I don't have any disclosures. As Liz mentioned, I practice primary care and addiction medicine at Harborview Medical Center, which is located in Seattle, Washington, and affiliated with the University of Washington. I don't routinely do HIV care. And Dr. Mears and I thought it would be helpful just to understand a little bit more about who's participating today. So we're going to ask you to complete this quick poll and just choose whichever selection fits your job role the best, please.
1 second, Dr. James. Poll is now live. I'm going to give it another 10 seconds, and then I'll close the poll. Okay. Broadcast the results.
Great, thank you. That's very helpful, thank you. I'll go ahead and move on. So these are the main points that I would like to cover today. I'll give a little background on substance use and HIV prior to COVID, kind of a quick snapshot view. And then I will share what I have been able to find out about impacts on people with HIV and people who use drugs during the COVID pandemic. I'll share some data on overdose deaths during COVID, and then finally turn to some recommendations for providers and advocates and the greater community, really. I think it will come as a surprise to none of you that prior to the COVID pandemic, pandemic, we were in the midst of an overdose epidemic that's been going on for a couple decades now, and unfortunately has been increasingly bleak. So in 2019, there were just under 71,000 overdose deaths in the United States, and opioids contributed to up to 80% of those deaths. There's a report from the CDC looking at data from January to June, so the first half of 2019, that found that 3 out of 4 opioid overdose deaths involved illicitly manufactured fentanyl. And I'll just refer to that from now on as fentanyl. I should mention that that particular report was not comprehensive for the whole United States, and different areas of the country had more jurisdictions reporting. I do think it overestimates this a little bit because the Northeast was overrepresented. But the key point here is that deaths related to fentanyl specifically have been increasing. But there's a lot of focus on opioids, and I think it's worth noting that rates of death from cocaine and methamphetamine have also been increasing dramatically in the last 5 years. So the top chart here is looking at all drug overdose deaths in the United States up to 2018. You'll see that there was actually just under a 5% decrease in overdose deaths from 2017 to 2018. Unfortunately, as we just saw, that trend reversed for 2019. And you can also see that there is a male predominance to overdose deaths. On the bottom is cocaine and methamphetamine is the green line. And just showing this to demonstrate what I just mentioned, that deaths related to psychostimulants are also really increasing. And as we'll see later, actually those lines cross by the present. So deaths related to methamphetamine actually overtake deaths related to cocaine. So what about the people living with HIV and people who use drugs? Although the HIV prevalence in the United States is estimated at about 0.3 to 0.4% overall, 1 in 10 new HIV diagnoses are in people who inject drugs. And I think it's important to note that this is not proportionate. It's increasing in non-urban areas where resources are often scarce, and it's higher among people living homeless, incarcerated populations, and people who are uninsured. Additionally, there are substantial racial disparities in HIV prevalence and in HIV care. On the left there is HIV prevalence, so this is rate per 100,000 population in the United States, and you can see that there is just tremendous disparity by race of the prevalence of HIV in this country. But importantly, on the right is the death rate per 100,000 population of persons with diagnosed HIV. And you can see that there are also tremendous racial disparities. And in fact, the likelihood or the death rate among African Americans, compared to white patients in the United States among people living with HIV is more than 6 times. So what happened? What do we know about the COVID pandemic and the time since it began, and how people with HIV and people with substance use are affected? I'll go through some of this, spend a fair amount of time on this, I think, because although I'm going to then talk about overdose, of course, is the end stage and, worst result of really what is an underlying substance use disorder and a lot of broader problems. I know that I feel like we've been in the pandemic forever and that will go on forever, so it was helpful for me just to remember that it actually happened really quickly in the beginning, and that a lot of changes occurred very quickly in society. We had to figure out how to respond. So in January 2020, the WHO first declared COVID a global health emergency. By the end of February, the United States had reported its first death. By the end of March, the United States was leading the world in confirmed cases. And by the end of May, there had already been more than 100,000 COVID-related deaths in the United States. So things really happened quickly. Turning to people living with HIV, 2 questions come up. Is HIV a risk factor for infection, or is it a risk factor for more severe infection from COVID-19? For the first point, there's mixed data on this, but overall, it appears that having HIV itself is not a risk factor for getting COVID necessarily. There are social determinants of health and comorbidities that go along with HIV that probably play a greater role than HIV itself. And then for people who, with HIV, who do contract COVID, do they get more sick? There's not a lot of data on this, but it looks like if people are on effective HIV treatment, they're not at increased risk. It is possible that people with low CD4 counts may be at increased risk. And again, comorbid health conditions probably play more of a role than HIV status itself. This is a study that's hot off the press from last month that looked at both of these questions. Do people with HIV, are they more likely to get COVID? Are they more likely to get more sick from COVID? And this was looking at public health data for about half of the year of 2020, a very large population. They found 270,000 people without HIV and had about 4,000 people with HIV, and they found that there was a difference in the COVID positivity rates, and that was a statistically significant difference, 4.5% among people with HIV compared to 3.5% among others. Importantly, only 44% of people with HIV had viral suppression at the last check. Only 55% were stably housed. They found that there was no difference in the severity of COVID illness, and the authors argue that they think this difference that they found is explained by differences in testing rates, with HIV, people with HIV being tested at a higher rate, and then also social factors like homelessness and congregant living. But the impacts of the COVID pandemic on people living with HIV extend beyond that individual person's risk of getting COVID. I think importantly, there's evidence that there's reduced access to care. So the same providers who care for patients with HIV are often pulled now, as for instance, infectious disease docs or public health experts to care for people with COVID or to work on the COVID response. So there can be a diversion of resources. And then visits have been canceled. In-person visits in particular have been reduced. There's also evidence of decreased availability of antiretrovirals. There's also increased psychosocial stress, which we know is already an issue for people living with HIV, or a particular issue for that population. And during this pandemic, they're likely to see increased isolation, increased stress, increased mental health burden. And there's some evidence that this might lead to reduced medication adherence and increased substance use. And then I think even more broadly, along with the pandemic comes this deepening socioeconomic vulnerability. We're seeing the safety net kind of fall out from under people. There's loss of income, housing, food security, social support, and at the same time a decrease in available services. This is an example actually from the same group from San Francisco. So briefly, this study was done at a San Francisco HIV clinic serving a safety net population and located at San Francisco General Hospital. And the authors looked at viral suppression and retention and care before and during the pandemic. And what they found is that no-show rates were equal, but viral non-suppression was about a third higher during the pandemic. And people living homeless had a higher odds of non-suppression than did others. So really, again, this is an example of data that the effects of the pandemic are really extending to the associated factors like homelessness and deepening socioeconomic stress and vulnerability. And those impacts probably extend to the entire care continuum of HIV. So these authors, Brown and all, give this good example, I think, of this entire care continuum from susceptibility to infection, as we've talked about, but also to testing. So HIV testing appears to be down. Prevention, PrEP uptake appears to be down globally, and treatment, where we have seen some decreased access to antiretroviral therapy. I'll turn now to people who use drugs. Are they more vulnerable to COVID-19 infection? And starting again with likelihood of infection, I think here there's a very strong case. There are a lot of factors that might increase vulnerability of people who use drugs to getting COVID. So just the act of procuring drugs could increase that. The vast majority of drugs are still acquired through person-to-person contact. And then just using drugs itself may lead to decreased distancing and decreased hygiene, so going outside to smoke, the hand-to-mouth actions, etc. And then people who use drugs are overrepresented in congregate settings, such as jails and prisons, opioid treatment programs, shelters, and food banks. And actually, of the incarcerated population, it's estimated that about 50% have problems with substance use. And turning to the question of are people with substance use disorder who acquire COVID or get infected with COVID, are they more likely to have severe COVID or more severe consequences? There's also a good case here that they are. So prolonged substance use is associated with a very high prevalence of associated conditions like heart and lung disease, smoking. Substance use itself can impair the immune response. And then importantly, people who use drugs also suffer from decreased access and quality of care due to stigma and discrimination, often have competing basic needs, reduced access to technology, and increased mental health burden. This is another kind of hot off the press paper that unfortunately confirmed what people were worried about. So this is a very large study based on electronic health record data, looking at more than 73 million patients in the United States, of whom 12,000 had COVID-19. And the authors found that people with substance use disorder were at more than an 8-time risk of getting COVID. And then they found that those with COVID and substance use disorder were both more likely to be hospitalized and more likely to die. Importantly, they also found that African Americans, compared to white patients who had COVID and substance use disorder, were more likely to die and actually were also more likely to be hospitalized. So unfortunately, when it comes to people with substance use disorder, again, there's a multitude of possible impacts on people who use drugs related to the pandemic. I think one example of this is disrupted care and support systems, disrupted routines, the loss of in-person social support, reduced access to medications for opioid use disorder, medications like methadone and buprenorphine, which are life-saving, also reduced access to psychosocial addiction treatment and to mental health care. And then as we've heard, people are, in some cases, because of COVID pandemic effects, incarcerated settings, people are being released early, and there's certainly some risk to people if they're being released without being connected to and adequately supported for mental health treatment, substance use treatment, social services, et cetera, that they may actually be at increased risk when they leave. There's also evidence of reduced access to harm reduction, and primarily here, I think the primary example is syringe service programs and everything that comes with them. So HIV testing, Hep C testing, fentanyl test strips, naloxone, and even referrals to treatment. And then there's evidence of changes in use patterns. So there were concerns raised very early on that with the COVID pandemic, more people would use alone, and that's a risk factor for overdose. And also, there's evidence that the drug supply has been disrupted by the pandemic, and this can lead to less pure drugs being out there, to more injection drug use, and also to loss of tolerance if people have gaps in their drug use. But stepping back even further, we know that there's a great deal of overlap in the neural circuitry for stress and emotion and substance use, and people with substance use disorder are at increased vulnerability to stress. Stress actually has been found to predict recurrence of substance use disorder in people who have been abstinent. We know that people with substance use disorder have high rate of concurrent mental illness, which would be likely to be worsened by stress. And there's a concern that they may have more suicidal or parasuicidal risk-taking. People with substance use disorder often really lose all their social support, their family relationships, employment, et cetera, and tend to have or be at risk for very fragile or absent social support. And then, as I mentioned before, stigma and discrimination can really make all of this worse. Stepping back even further, again, this population has higher rates of socioeconomic instability, which is likely to be worsened during the pandemic. And there is evidence that unemployment is associated with an increased overdose death rate. Finally, looking really at the long term, the COVID pandemic is likely to contribute to the slowing or stopping of some substance use disorder research. I wanted to share just quickly a couple highlights from this report. It's from the United Nations Office on Drugs and Crime, and I find this a really fascinating read. It's a lot of information that I didn't know much about before looking at it. It really tracks drug supply kind of from production all the way to the end user. And I'm just highlighting a couple of things. So some general effects. In general, drug shortages tend to then lead to increased injection drug use and decreased purity of drugs, and also economic downturns such as we saw in 2008 have led toward increased overall substance use, also increased injection drug use, which of course would confer higher risk of acquiring HIV, and also a shift toward cheaper drugs. And then specifically, there are some likely effects on the North American drug supply. So we get most of our we get a lot of our drugs rather from Mexico, and there's evidence that reduced trade from Southeast Asia to Mexico has decreased the availability of the chemical precursors for both methamphetamine and fentanyl. And there's evidence in the United States that COVID has led to shortages of heroin and shortages of cocaine as well. I also wanted to just share an example on harm reduction. This is a paper, I believe from December, looking at syringe exchange programs that were surveyed throughout the United States through this syringe exchange network. The researchers ended up getting data from 173 programs, and 43% of those reported a decrease in available services, including medications, again, life-saving medications for opioid use disorder. 25% of them reported closure of one or more sites. Most reported that fewer people were seeking services, and importantly, nearly all reported HIV and hepatitis C screening had declined, or more commonly had been eliminated, usually because of concerns about doing blood draws and trying to keep staff safe and maintain some physical distance. I also just want to note that although telehealth has been, of course, very useful during the COVID pandemic, it doesn't work for everyone. And I think that people with substance use disorders, many of them fall in this category. They may not have phones or Wi-Fi. They may have mental health and behavioral challenges. And I think in particular, patients who are homeless really need the in-person clinic services that come along with their clinic visit, the social support services. I'll now turn to share some data on overdose deaths during COVID. And I'm going to go through this fairly quickly just in the interest of time, but I'm happy to also come back to it if there are questions later if people want to look at it more carefully. But before we even think about overdose, there were early reports of increasing substance use during the COVID pandemic. So this is a morbidity and mortality report from the CDC. They surveyed U.S. adults, and they found that 40% of U.S. adults reported struggling with mental health or substance use during the COVID pandemic, which is a very high number. And they found that 13% reported that they had either increased their substance use or newly initiated substance use. And you can see there that some people in particular were at higher risk. So again, the risks are not proportionate. And this was not the only report that showed this. There were other reports that showed similar findings, that more people were turning to substances, which is really not surprising given what we know about substance use in the setting of stress, in the setting of an economic downturn, et cetera. And then very early on, there were alarms raised about increasing overdose. Lots of newspapers reporting some really tragic stories and anecdotes from providers and families, et cetera, that people were dying at higher rates during the pandemic. This is from the Washington Post, which looked at data from ODDMAP, the Overdose Detection Mapping Application Program, which is a program that uses pretty much real-time data about overdose, both fatal and non-fatal. The Post did an analysis and found that for May 2020 compared to May 2019, there had been a 42% increase in fatal and non-fatal overdose. And so this corresponded to, for every 10 people who died, or excuse me, who overdosed in 2019, in May in 2019, 14 did in May 2020. Similarly, some data from Michigan, looking out a little farther from March to mid-September, found that deaths overdose were 15% higher than they had been in 2019, and also that EMS, emergency medical services, administrations of Narcan or naloxone were almost a third higher. There's also data that cardiac arrest related to overdose increased during the pandemic. So this group has data that represents more than 80% of the national activations of emergency medical services. And they found, as you can see on the left here, they found that there was a real surge in overdose-related cardiac arrest in that kind of first wave of the pandemic, April, May. And then interestingly, they found that that coincided with these scores of mobility, and they used cell-based mobility estimates. And so on the graph on the right, that bottom line is showing that mobility went down, and kind of just prior then to the surge in overdose-related cardiac arrests increasing. I think it would be very interesting to see this data extended out to closer to the present. But I think the big confirmation that all these reports and fears were real and unfortunately were correct came from the CDC's report in December that came out. So they issued a health advisory that announced that in fact, there had been a substantial increase in drug overdose deaths. They found that in May 2020, there were over 81,000 deaths. For the year ending in May 2020, there were over 81,000 deaths, and that was the highest ever recorded. It was an 18% increase from the prior year. And subsequent to that report, that data has been updated. So by last month, the provisional data, and this is estimated, so it accounts for incomplete reporting, but the provisional data suggests that there are more than 83,000 deaths in the year ending June 2020, and that's a 21% increase over the year prior. I think it's important to remind ourselves that overdose deaths were going up again prior to COVID pandemic, and that fentanyl is playing a huge role in this. In this chart is nationwide data, again, from the CDC and the National Center for Health Statistics. The black line there is opioid-related overdose deaths. The brown line is fentanyl-related overdose death, and you can see that really shooting up along with the total. And then the pink and gray lines that are a little bit harder to see lower down, but those are methamphetamine and cocaine, and you can see that the gray, which is methamphetamine, actually overtakes deaths from cocaine, as I had mentioned earlier. But really the big picture is fentanyl is driving these infant overdose deaths in the United States. And the West Coast is experiencing particularly rapid change right now. Methamphetamine is playing a particularly large role on the West Coast, and the change, although fentanyl-related overdose deaths are still more common on the East Coast, the pace of change on the West is really scary. So if you look at that bottom map, this shows the percentage increase in fentanyl-related overdose deaths, and the dark red are states that have had more than a 50% increase in fentanyl-related overdose death, and you can see that there's a geographic pattern there. And in fact, 10 of the western states have basically had a doubling of fentanyl-related overdose deaths. And this chart is a little bit hard to take in all at once. I'm just going to focus on the column on the left. So this is drug overdose deaths for all drugs, totals, and each of these bars represents a one-year period that ends in that given month. So it goes through May 2020. So the darker red bars are basically the years ending in March, April, and May of 2020, essentially during the COVID pandemic. And what you can see there is that in addition to drug overdose deaths steadily increasing, there are these month-over-month increases that are actually the largest ever documented, and that really show an acceleration of drug overdose deaths during COVID. So it is thought that this really supports that although drug overdose deaths were being driven by other factors such as fentanyl, that the COVID pandemic, in fact, really is driving an acceleration in drug overdose deaths. So I'll turn now to some thoughts about ways that we can try to reduce the risk of people dying from drug overdose. I think importantly, we need to really raise awareness. We need to make people aware. And first, that the risk of fatal overdose is increasing. People should know that fentanyl is mixed not only with heroin, but often with counterfeit pills that might be marketed as benzos or opioids, really anything obtained on the street. That it's also mixed with stimulants, although less often. And that methamphetamine, both with and without opioids, is playing an increasing role in overdose death. I think a lot of people that I've talked to are very aware about the risk of dying from an opioid overdose, but less so that you can die from using methamphetamine alone. And also that co-use of opioids and stimulants increases the risk of a fatal overdose. We need to make sure that people know that naloxone is life-saving. We should encourage everyone to have it and to use it. And because of fentanyl, it's important to know that one dose of naloxone or Narcan may not be enough. So you start with the recommendation is to start with the usual dose, but to repeat that dose up to several times if needed for a single overdose. And similarly, it's not enough to administer naloxone. 911 should be called immediately. And then some other basic harm reduction advice, of course, is also important. I think in the pandemic, we need to be clear that it's still not safe to use alone. Take precautions if possible. If you are using alone, there are phone lines that you can call to have someone at least on the phone with you. Know what your drugs are, know what you're using, especially in this time where drug supply is really disrupted. Use fentanyl test strips if you can. Go slowly, and if you're a family member or friend, check in regularly on that person. I think it's clear we need to increase access both to harm reduction and to treatment. So for harm reduction, we really need to expand the locations in which we're offering overdose education. We need to expand access to fentanyl test strips and to naloxone. And services need to adjust to pandemic needs. And actually that syringe exchange program survey that I shared earlier, there were some positives from that. The researchers did find that a lot of programs were being quite innovative in terms of using vending machines or lock boxes, or when they distributed supplies, they were giving more at once. They weren't sort of doing the one-for-one approach. And then treatment, of course, treatment access is hugely important. So methadone and buprenorphine, again, are life-saving for people with opioid use disorder, and we need to expand access. And that could include things like mobile vans to get out to people who are not able to participate in telemedicine. We should try to reduce administrative barriers, and there have been some regulatory changes during the pandemic that some people think should be continued beyond it. We should make it easier to prescribe buprenorphine, and then access to stimulant use disorder treatment, which is really mainly psychosocial treatment, sometimes medications, is also important. Access to mutual support groups, and I think really importantly, we need to bring addiction treatment into the mainstream of medical care. I have highlighted some examples of where the effects on people, I think of people who use drugs as being a very vulnerable population overall, but among them, some are particularly vulnerable, and I think it's really important that we prioritize those people. We identify and prioritize them. So people who've had a prior overdose are at high risk. They need post-overdose response and follow-up. Those who are transitioning, whether because they're leaving an incarcerated setting or they're transitioning out of care, really need to have aggressive harm reduction. They need to have access to harm reduction, and they need to have access to medication treatment. And then people just generally more vulnerable because of various socioeconomic factors or racial minorities, people with higher burden of mental health disorder. I think this is really a very important part of the population that we need to focus on. And really here, again, the safety net is falling out in many places from under them, and I don't think we can slow overdose death really without addressing basic needs such as food and housing and making sure that essential services remain accessible. And finally, I do think there is a role for addressing racism and also stigma, and that by doing better with that, we can make a difference. I'm not going to actually go through this slide. I know you'll have access to the slides and welcome to look at it. This is, I think, a really great report from Johns Hopkins that includes a lot of policy recommendations that might help save lives from overdose. But I just want to turn and talk a little bit more about stigma. As you may be aware, injection drug use is the most highly stigmatized condition worldwide, and stigma affects access to care, it affects quality of care. It helps explain that addiction care has been so marginalized, and it really affects people at the brain level. There's evidence that it relates to, it increases stress and isolation, that it worsens mental health, and that actually the experience of stigma in some cases leads people to use more. And what we say and how we act really matters. So here are a few recommendations that we might be able to implement however we're interacting, whatever our role is in our interactions with people with substance use disorder. So health providers really need to be educated that addiction is a chronic and treatable disease. We need to be compassionate and respectful. We need to follow the motivational interviewing recommendation of using unconditional positive regard. There's some evidence that emphasizing solutions and actually also having treatment available reduces stigma. My interpretation of this is that when people see that they can do something positive, when they see that a treatment works, that it's sort of normalized more as a medical condition. And then language matters, and we need to use person first and medically accurate language for people who use drugs, just as for other conditions. So here are some examples. We would prefer the terms person with substance use disorder, a medication for substance use disorder, rather than a clean or dirty urine, speaking about a negative or positive urine test. Recurrence of use rather than relapse, which is a really loaded term, and then being in remission or being in recovery. So in conclusion, people with HIV and people who use drugs during the COVID pandemic are increasingly involved in the syndemic that also involves basic needs, racial inequities, and stigma. COVID-19, fentanyl, and methamphetamine are causing a perfect storm leading to accelerating overdose deaths. There's an urgent need to expand access both to harm reduction and to treatment for substance use disorder, and to bring substance use disorder care into the mainstream. And efforts should really prioritize the most vulnerable and should address existing disparities. Thank you. I think Liz can let me know how much time we have for questions. I'm happy to take questions that people have.
Great. Thank you so much, Dr. James. That was wonderful. Yeah, so we have a few minutes for questions before we move on to Dr. Muir's presentation. So I welcome all participants to either unmute yourself by pressing pound 6, or you may use the participant chat to ask your questions. So our first questions are, what are your thoughts about the decriminalization of small amounts of drug possession in Oregon? How do you think it will impact care services that are already stretched?
That's a really excellent question. I have been thinking about this a little bit. I admit I haven't actually read in detail about Oregon's case in particular, but I did read in thinking about ways to potentially mitigate the risk to people with substance use disorder. I did read some pieces that were arguing for these kind of more, I would say, less routine harm reduction and a little farther to the little what some people would see as maybe more extreme. I do think there's a really important case to be made for decriminalization, in particular because of the issues with racial justice and the fact that people with substance use disorders have really been treated, differently based on race, and incarceration has played a really big role in that. So I do think that it's helpful. I also feel that right now, just with such a crisis, such a combination of crises on us, it's kind of my sense that we should focus on the things that we have more agreement on, that we can more easily implement and kind of gain ground more quickly. So I guess I would say that's a long-winded way of saying I'm glad to see it. I think probably the emphasis should be on things like making sure people have basic needs met on naloxone and sentinel test strips and access to medications, things like that.
Great, thank you, Dr. James. And then another question that we had in the chat box is how to address racism with regard to healthcare disparities.
Yeah, also such a big and timely question. I have seen, as I'm sure a lot of you have, I know at my own institution there are a lot of efforts to try to do a better job with this. I think it's beyond, I'm not an expert. I would be interested in others' thoughts on this and on Dr. Mears' thoughts on it as well. But I mean, in general, I think we need to talk about it. I think we need to ask people and involve people of color and particularly Black patients in care and in the design of care delivery. I think they really, I think we need to have much better representation in how we, in the decision making and the design of care delivery. And I do think, as I mentioned earlier, that particularly for people with substance use disorder, that racism has played a lot into how people are treated by the legal system, and I do absolutely think that we need to address that.
Dr. Mears, do you want to add anything?
I agree with Dr. James. It's a really big question that is really hard to encapsulate in like a few minutes answer. I think that without doubt, systemic racism has impacted substance use and how substance use is viewed and the stigma that's associated with it. I think that it plays a huge role in all of that, and I completely agree. I think that we need more Black, Indigenous, people of color, or BIPOC in our medical leadership, and I think that we need to have these conversations, and there needs to be dedicated money set aside to hire consultants who are trained experts in this and not just be trying to navigate this field alone. So I think that there's so many other pieces to it, but that's just some quick thoughts about it.
So another question to add, how do we address provider stigma?
I think this is really key. I think we need to educate better. A lot of healthcare providers across disciplines really don't receive at all adequate training for working with people with substance use disorder, and it's often seen as kind of an add-on, I think, to care, whereas, you know, I consider substance use disorder a huge part of medicine. If you put all substance use disorders together, you know, the prevalence is incredibly high. The impacts are really high. Like other conditions, it's normal to have periods where people are struggling more and then where they're doing better. It's not going to go away. It's a chronic condition. And I think there are so many just basic elements of understanding what substance use disorders are. And so I think we need much better education. There's also some data that just doing more substance use disorder treatment helps with stigma. And we've been doing this in our clinic. We have a buprenorphine, office-based buprenorphine program that was started in early 2016, and we looked at views of both staff and providers before that, and then about a year in. And we did find that staff and provider views changed in a small sample, but you know that they changed, and I think there's some other evidence to support that just doing the work and being around people with substance use disorders helps. And again, I would just highlight that I think that is related to the point I made earlier about stigma, that I think it's just kind of human nature that when we see that this is a problem I can do something about, I can give you a medication that is way more effective than any of the medications I can give you for your coronary artery disease or your heart failure. Like the impact of methadone, which I can't prescribe, or buprenorphine, which I can, it like blows those other medications off and out of the water. And being able to do that and partner with patients, that makes you feel good as a provider, and I think that it really does help with stigma.
Great. Thank you, Dr. James. And again, Dr. Mears, anything from your perspective to add?
Yeah, I think that we need to actually start right from the very beginning. I mean, educational opportunities in colleges and things like that. When we're teaching people to be nurses, to be medical providers, whatever, APRNs, PAs, MDs, PhDs, PsyDs, whatever, that we start from the very beginning and we normalize that shifting your reality and that desire to shift your reality, which is what substances do, is part of the normal human process. So it's really starting at the very beginning of the educational process, and then repeating that education, normalizing it in every way and every aspect. That I remember I had a nurse come up to me and said, "I think my person in the room is high. How do I talk to them? I talk to them just like they're a normal human being, because they are a normal human being, right? Like that we can kind of shift away from that there's something that we need to do differently because of that, of the substance use, that we treat them with respect, and when people begin to, just like Dr. James said, become comfortable and see that, wait a second, these are just normal people who are struggling, that it becomes less of a stigmatized thing. But I think education right from the very beginning, and a paradigm shift. No big deal, right? Something small.
Excellent point from you both. Thank you. Before we could take one more question, if anyone has any additional questions before we move on to Dr. Mears. We'll also have another Q&A section after Dr. Mears' presentation. So, and if you want to unmute yourself, it's pound 6, and you can also add your questions to the participant chat. Dr. Mears, I think it's safe to turn it over to you, and then we could again address additional questions after your section.
All right. And so I feel like my camera's not great, so I apologize for that. And also, I don't actually have a disclosure slide, but I have nothing to disclose. I do work full-time in HIV. I'm very privileged to do so. I really love my job. And so I'm going to be speaking about suicide. I also just want to acknowledge that this is I mean, Dr. James was just talking about overdoses, and I'll be talking about suicide. I recognize that these are both really weighty topics, and that we aren't presenting good news, right? We're not seeing trends of reduced overdoses. We're going to be talking about suicide. We're not seeing suicide numbers going down. So I do just want to say at the end of my presentation, we are going to be talking about some positive things. Having trained in suicide and worked worked with high-risk individuals and gone to presentations and trainings and conferences about this, it seems that whenever we end on a more positive note, it can give us some sense of hope that this isn't just everything's bad and we're going to hell in a handbasket kind of thing. So I just want to acknowledge that I do know that this is a hard topic, and hopefully I will address it with grace. So I'm going to post something in the chat really quickly. It's been sitting there, so to go through. This is actually an article that was just, I'll talk about it in just a few minutes, but it just came out on the 3rd, so that's the citation for it. If you don't have access to journals, I am happy to share this with you, as actually any of my slides, which we'll talk about that in just a minute. But so this article came out, and I'll come back to it. Just generally, statistics around suicide. There's a lot of information on this slide. Numbers continue to go up. That's really the takeaway from this. When we break suicide down into specific categories, sexual orientation, gender identity, ethnicity and race, that we see that there are certain groups that are much higher than others, and so it's not looking good, right? Suicide is very, very high, and these are a little bit outdated. The research that I just posted into the chat, that one has more updated, but again, it just came out on the 3rd, so I wasn't able to put it into my slides because I actually just found out about it today. But yeah, the numbers are not good, and we continue to see increases. When we start looking at some of those different groups, we see that cisgendered men are more likely to succeed at suicide attempts, and cisgender women are more likely to attempt. And I know that 53% of our current audience is our counselors, social workers, or caseworkers. So some of you guys might be familiar with this information, right? We know that cisgendered men are more likely to use more lethal means, that cisgender women are more likely to use non-lethal means, so that's the difference between using a gun or hanging yourself to using pills or something like that. So the differences are going to impact lethality. And we also know that suicides among trans individuals are higher, and we also see that people who are living with HIV are at even more risk, and especially if they fall into, again, another one of those smaller groups. And what isn't on here is also, again, race and ethnicity, and this is in my references, but that there is currently extremely, really, really high rates for Black young men and suicide. Their suicide rates are extremely high, and this is cisgendered men that I'm talking about. So Black cisgendered young men, up to 20, I think it's up to 25 or 26. My apologies, I don't remember the exact statistics. I should have put it on the slide. But that these young men are at really great risk. So sexual orientation and suicide, and a lot of the research that I found was really just looking at lesbian, gay, or bisexual individuals. Again, bisexual individuals are often at the highest risk. Lesbian and gay individuals are at higher risk than heterosexual individuals, but they are we continue to see it climbing. And I thought that this quote was so appropriate, that regardless of the sample type examined, sexual minorities have a higher lifetime prevalence of suicide attempts than heterosexual persons. And at least in my work working with people living with HIV, I know that the majority of people that I see fall into a sexual orientation minority, if not others. Hopefully you guys can see my webcam again. I turned it on when I got kicked off, and then I had to click an extra button. I didn't realize that. For suicide in people living with HIV, that we're really seeing that twice the rate. So whatever the general population's rate is, we tend to see that people living with HIV, they're completing suicide at twice the rate of the general population. So really, really concerning numbers. And having multiple physical conditions increase suicide risk substantially. And if we go back to thinking about what Dr. James said earlier today, that people living with HIV are often at risk for multiple other health issues, right? So, and Dr. James was talking specifically about COVID, and so are people living with HIV more at risk for COVID? Well, not necessarily, but if they have multiple other diagnoses, then they could be. And so just in that same way, multiple physical health conditions can increase risk for suicide. And so this is just some other information. If you're interested, there was this really interesting editorial back in 2015 written by a medical doctor that spoke about how he had anticipated that after ART had come out and we would see such an improvement in health, that HIV rates of people living with HIV dying by suicide would go down, but they did not. And so asking the question of why. We do definitely have research that suggests that cisgendered white men with HIV who inject drugs are at the highest risk for suicide. That was from one specific article, but there's other research again to suggest that people who inject substances are at higher. So again, we can kind of see how it's these different groups that are at high risk, and then when you put when someone has multiple of these aspects, it puts them at, I mean, the numbers are just the multiplication, like they're exponential. Risk factors specifically for people living with HIV and suicide include within the first year of their diagnosis, people who are out of care, and people who are perinatally infected. I know that in my work I see that that suicide risk is very high for people who are perinatally infected. Having gone to the HIV and Social Work Conference, if you haven't gone, I strongly suggest it. It's fabulous. But there's often conversations about that at that conference. And just I know Dr. James already covered it, so I only included just some really brief points on here. That all substance use is associated with higher suicide risk. Here's cigarette smoking again, right? That smoking cigarettes, it just gets in there. Specifically for people living with HIV, that it increases the risk of suicide, and cisgendered men who inject, as I mentioned for you, are, for some studies, at highest risk. So what impacts suicidal ideation? We definitely know from research that perceived burdensomeness, thwarted belonging, and intense emotional distress. Those are the big three. Acquired ability, that's just the ability to acquire means that you need to complete. So that absolutely has a role in it. And a sense of hopelessness, definitely. We have research that supports all of those things. I have mental illness with a question mark after this because there's some research, there's a lot of argument within suicidology, like the study of suicide around this of does someone actually have to have a mental illness in order to be suicidal? Like, does the fact that you are suicidal mean that you automatically have a mental illness? And there's some research that suggests absolutely yes, and other research that suggests no, that's not the case at all. So thinking about that and considering that, it's not clear, and I'm not here to make a judgment either way, but just knowing that that's a part of that conversation, that we saw with the Great Depression in the 1920s that intense emotional distress, just from like loss of money in the stock market, for instance, resulted in people taking their own lives. So does that necessarily mean that those people who moments ago were completely fine before they knew about the situation, does that mean that they had a mental illness, or was it just that intense emotional distress that they felt like they had no other alternative? So something to consider when thinking about suicide. I'm going to check something on my slides really fast. Okay, I just wanted to make sure I hadn't skipped one, because later. So what is the role with COVID and suicide? There were so many things. I had to stop listing things. It got too hard to see. I think that whenever things are tiny on slides, it makes it so hard. So I wanted to keep it, but I'm sure that we could even come up with even more than this. But isolation, hopelessness, intense emotional distress, definitely perceived burdensomeness, thwarted belonging, and fear of others, which has been a huge thing coming up with COVID, right? This I can't trust other people. I think that actually that also plays a role in what we've seen with the increases after family gatherings, like over the holidays. We saw these increases in COVID diagnoses because you're with your family members and you trust them, right? So you're removing your mask. But that person at the gas station or that person in the grocery store, there's that fear that you're going to get COVID from them. Grief and loss, absolutely. It's so profound. There's so much loss, and not, again, just from COVID, but grieving the loss of connection and grieving the loss of an opportunity. I know our program always does a vacation opportunity for a lot of our families where they can just get away, and it's their only opportunity to get away from their households for just a couple of days, and we weren't able to do that this year, which was so devastating. And this general sense of unpredictability, we don't know what's going to happen next, right? The news is saying COVID numbers are going down, but then we're finding ourselves saying, well, is this because of the vaccine or is it because of something else, right? We're on edge about it. Financial unpredictability. And I didn't put instability because we just don't know, right? Are we going to get the unemployment extension? Are we not? Is my parent going to be able to go back to work, or am I going to be able to go back to work? There's so much unpredictability, which as humans we don't like that, and it creates more anxiety. The overall unemployment rate. Access to means, again, is going to play a role, and because we're home, there's more time to find ways to be able to access means or to create some kind of access. There's medical unpredictability. Appointments are being canceled. Can I go to my doctor? I know I work with someone who also has MS, and so they get confused in their appointments, and they were told that they can't have a scribe in there with them initially, right? Now they can. Things are calm, but they were like, how can I even complete my appointment? I don't remember what happened. So this unpredictability of what's going to happen. Can I go to my appointment? Cannot. Even the political climate, and I'm not here to make any kind of political statement, but just the political climate of uncertainty and lack of clarity and things like that has been so stressful. And a lot of loss, again, in our ability to engage in our coping skills, our normal coping skills, and how we used to move through the world has just been really removed from us. These are some hypotheses around suicide and COVID that a lot of researchers, when I was looking at current research around suicide and COVID, a lot of things that I found were actually like letters to the editor. And really, we didn't have, at the time when people were writing these, we didn't have really any good data, but people were expressing such profound concerns, and those are included in my reference section, where they're talking about there's going to be, like, there's likely this increase in suicides during COVID, which the article I referenced at the beginning demonstrates that there has been an increase in suicide over the past year. But afterwards, when we're when we're emerging, right? I don't know how many of you are familiar with the seasonal impact of suicide. What we see is very much in the springtime, there's an increase in suicides, and there's lots of theories about why this happens and the role that weather and temperature plays on our emotions. But one of the things that we can see is that when people are emerging out of seasonal, kind of that malaise and seasonal affective disorder, that people with major depressive disorder often don't feel any change and see everyone else kind of blossoming around them and feeling so relieved and getting some kind of relief where they do not. And so there's higher rates of suicide in the spring. And I think that there are researchers who are concerned that there's going to be a similar kind of occurrence where when the when things begin to be lifted and people are feeling such profound relief, that people who've experienced intense grief or are experiencing depressive episodes are going to feel that thwarted belonging and then turn towards suicide as an option. There's also fears around an economic crisis and leading to rises in suicide. Again, I mentioned the Great Depression earlier, and that we know that when economies are doing as profoundly poorly as ours is now, that there's definitely a rise in suicide. We don't know about the long-term impacts of even being diagnosed with COVID, not just the stigma of, oh my gosh, you had COVID, or how did you get COVID, but rather, what are the impacts on our brains or on our bodies? We don't know those yet. Survivor's guilt. So there have been family get-togethers where so many people have died after that get-together, and then the survivor's guilt afterwards. Sense of isolation. So many people are isolated right now. In New Hampshire, rural New Hampshire, there are people who live independently on their own, but because of COVID, don't have any of the normal social interaction that they typically, feeling like a burden to their family, whether that's because they need care or because they typically live isolated and can do things, but now they're scared for their own health. These are some things that have come up. We don't really know how COVID will impact suicide as we begin to change, but again, from that article that I posted in the chat, we do know that there has absolutely been a statistically significant increase in suicides since the beginning of the COVID pandemic back in 2020, in January 2020, really, when we started hearing about it. We don't know how social distancing and isolation are preventing a sense of belonging, or even the sense of community, right? There's this possibility that there could be this sense of global community, definitely for our younger generation who's more connected and into online communities than some of our older patients that I see, for instance. But there's also kind of this friction about, are we in this together, are we not? And perpetuated by attitudes and lack of clarity around like mask quality and things like that, or even how to wear a mask. And what is even in place? Like what's in place is inadequate prior to COVID. So then now that we have all of these other things weighing on us at this time, how are our systems that are already so inadequate going to be able to help catch these individuals as we begin to come out of it, and kind of how do we prepare for the fallout? These are just some different, again, these kind of categories or impacts that people living with HIV, and then when we add in COVID onto this, how is this impacting them? So one of the largest groups for people living with HIV is our aging population. Marginalized groups, the stigma related to HIV, right? Like that, all of those go hand in hand. So racial and ethnic disparities. These individuals who whether they're BIPOC or sexual orientation or gender identity, like the minority groups within those, how those play a role in COVID and the disparities. Food insecurity, housing insecurity, and again, financial insecurity as well. And to speak to the medical uncertainty too, just like Dr. James said, I can speak from working in an infectious disease department that we definitely saw our providers being pulled to work in COVID related areas. And our state resources, which New Hampshire has very few already, but our state resources, I mean, poof, like gone because they're working with COVID, and that's their focus, right? So resources that were already stretched are even more. And so I just want to, here's the part of the presentation where I'm going to move into a more positive piece about hopefulness now that I've presented you with all of this really discouraging information. I just want to acknowledge that people with HIV are amazingly resilient. Just really, truly incredible. People who are long-term survivors have such wisdom from a previous pandemic that you might be familiar with, HIV, right? And also we can help people living with HIV and help ourselves by practicing skills that increase resiliency. And so what is resiliency? And it's the practice of engaging in specific behaviors that support mental wellness and coping with challenges. There's a really fabulous organization called the Bounce Back Project that I think it's bounceback.org. But if you just Google Bounce Back Resiliency, you'll find it, I promise. But they talk about how to increase resiliency in such a beautiful and engaging way. So just the 5 pillars of resiliency: self-awareness, mindfulness, self-care, positive relationships, and purpose. And when we think about suicide, we can see how these are very, that they can help challenge those feelings of suicide. Specifically purpose, I think, in positive relationships, but self-care is important too. So I'm going to talk about those pillars as quickly as I can, knowing that we only have a few minutes. Just really fast, resiliency is not a quick fix. It's not a treatment modality, and it's not easy. So it's an ongoing process. It's something that you strive to do. It's not something that we can just prescribe to our patients or just give to them. So these are just some really basic strategies to start thinking about and increasing resiliency in your own work with your own clients or patients. Asking questions, using active listening, helping patients or clients identify strengths, being the positive relationship for that person, someone that they know that they can go to. Providing education, so important. I had a patient sitting in my office last week talking about how COVID isn't a big deal, that it's not worse than the flu, and really stopping that and providing some real education around that. And connecting them with mental health supports. If that's not you, then that might be other organizations or it doesn't even have to be. Like if you're the therapist, like how can you connect them with different mental health supports in their area, support groups or other different. These are just some really quick, I think it's so important to provide practical things, really quick strategies for self-awareness and mindfulness, which really I think overlap. Right? When you're practicing mindfulness, you become more self-aware, so they can really beautifully connect within each other. Mindful physical activities are walking mindfully, eating mindfully, those kinds of things. And sensory activities are things that you're doing specifically to engage your senses. So holding on to something, touching something that might be warm or soft or smooth, or like kind of really being very intentional and focused about that, and noticing what you enjoy and what you don't enjoy, or how it impacts. Let me just say too, interfinger space is holding up your hand in front of you and thinking about the space between your fingers. Just thinking about that space. Just what is that space between my fingers? Your feet and socks activity is thinking about what your feet feel like inside your socks, inside your shoes. That's a really intentional, mindful activity. It's bringing you back into your body. Intense exploration of an object is taking any object and using your 5 senses to really intensely explore it. If you're going to use something like a pen, don't lick it, right? But you can do it with a bottle of water, and then you could drink the water or something like that. So those are what those activities are. Self-care isn't necessarily about bubble baths, but rather, what do I need right now to keep going? And I think that's a really important question to ask when someone in front of you is really struggling, whether they're suicidal or not, just when, especially with everything that's going on with COVID, just what do I need right now? What do you need right now to keep going? What can you do for yourself to keep going? What's realistic? And then positive relationships. If we think about that thwarted belonging and the burdensomeness, positive relationships help you to know, right? They help reality check that you're not a burden, that you should be there, that you are important. And those are just some. The consider relationship is an exercise in that. Your sense of purpose is going to be tied up and linked in with your values. It's your reason to keep moving forward. Doing a value sort, defining those values, and even asking someone, what do you want in your life? What would a perfect life look for you? Can help you pull out what those values are and what's meaningful to that person, and then from there beginning to kind of define that. People might struggle with that, and you can always ask, what is it that you don't want in your life? Sometimes it's easier to answer those negative questions than it is those positive ones. And then these are some different supports and a variety of resources that are available in my slides. Oh, there's the Bounce Back Project on there. And I'm happy to answer any questions.
Thank you so much, Dr. Mears. Again, another excellent presentation. Before we get to the question that's in the participant chat, I just wanted to let everyone know again that you can unmute yourselves pressing #6, or you can enter your questions into the participant chat. And then, Dr. James, if you want to join us for the Q&A. So I'm going to start with the first question is from Judy. What is the data on healthcare providers at risk for suicide or who have committed suicide due to COVID? Are there any suicide trends for healthcare providers who are treating people with HIV and COVID?
I don't have that specific information. I think that's such a great question, though. So I'm so sorry I didn't think to look into that information for you guys. I do have to say I've definitely heard about healthcare providers, suicide with healthcare providers going up, but again, I don't have the statistics on that. I think that we can definitely assume, again, because we're seeing an upward trend with the suicides in general, that there probably are healthcare providers that are completing suicides at this time. But I don't have those.
Dr. James, anything to add to that and your thoughts in general?
Are you able to hear me? Did I unmute
Yes.
myself? Okay, thank you. I share that it's a great question, and I actually, because I could do this, saw it in the chat. I tried to look up. It does look like there are a number of studies that would be interesting to look at reporting on suicide or mental health and healthcare workers. I haven't reviewed that, but I share what the impression that Dr. Mears said, and probably I would guess a lot of us have seen just news reports of burnout, of increased mental health and stress, and the occasional reports of doctors or other healthcare providers committing suicide. So I'm sorry I don't know more. I'm interested to look at the studies.
Thank you both. For our next question, so with COVID-19, the mental health services at my office is able, my office is able to assist clients with is just telehealth. Do you have recommendations or suggestions for clients that are resistant to telehealth?
I think that this is the magic question, right? Like, how do we get people engaged in care when they're not willing, like they're not engaging in care? I have done a variety of different in my own work. I see patients in person. I have telephone calls, and then I also have telehealth video calls, but continue to struggle with that same challenge of how do we get people into care. And I think one of the best answers that I have, which isn't a great answer, but it's meeting people where they're at. So telephone calls to people, trying to be as flexible as possible with working with them. Some people will only talk to me for like 5 minutes, but they're willing to talk to me for 5 minutes 2 times a week. And another person who has never engaged in mental health care spoke to me for half an hour, and I was like, that's a win. At least we got you in for that long, right? So really just, I come from a trauma-informed care perspective, which is even if someone is late, even if they no-show you and then they text you right back, really encouraging people to just engage and accepting them with open arms and assuring them that it's a safe, non-judgmental space. Doesn't necessarily mean, like I definitely have patients that are hard to engage or don't engage with me that I worry about. So I know it's not the best answer, and I apologize. I don't have a magic wand. I'm so sorry. But really coming from that perspective of I'm just really excited that you're here, and I'm really glad that we're talking, and I know that this is hard, and I know that this is uncomfortable, and I also really believe that I can help, and if you're willing to give me that chance, and let's do it at your own pace.
Great. Thank you, Dr. Mears. And Dr. James, again, anything to add for that question before we move on?
Well, I'll just say that I do feel, I do really feel that we should try as best as possible while protecting staff and taking other concerns into account. I really do think that we should have a spectrum available for people because we know that one size doesn't fit all. And I think as much as possible we should maintain some in-person support for some of the reasons that that I went through and that Dr. Mears has talked about. And I find that it's just my perception that some of the people who are really resistant to telehealth are kind of a higher risk group to begin with. There are reasons that they're resist telehealth, and they are not, clearly not putting their own kind of infection control at the top of their priority list, probably because there are these other really pressing competing needs. So I think as much as we can to maintain some access is ideal, but it's certainly a struggle, and there are a lot of other interests that need to be protected as well.
Thank you. So this next question is kind of a same participant asked this question, and I feel Dr. Mears, you kind of addressed it in your response, but the other part of that question was how to assist clients that state they want mental health support, counseling, medication management, but never follow through with the appointments referral, although they express a strong intention to engage and want the service.
I think, again, I'm coming from my trauma-informed care perspective on this, of that I have someone who I have been trying to, doing the exact same thing, calls me, well, like at one point, they are substance users, they use substances as well. So they texted me like 17 times before 8 in the morning one day, which is when I start work. They tell me so intensely that they want to engage, but then they never show up to any of their appointments, whether those are telehealth appointments or in-person appointments. They don't show, and for me, like just getting and so they did show at one point, and they were only able to tolerate for 30 minutes. That's how intense their distress was, and even just being there. So. And my thought is just, I am so glad you're here. You made it. We're going to figure this out together. We're going to move at your own pace. Again, so many of those things that I already said, really just trying to meet that person where they're at. Because when we can do that, they have already, they're coming in with so many ideas about who we are as providers, about how we're going to engage with them, about our perceptions or their fears about our perceptions, right? And when we can really just try and bring them down and help develop that trusting, might not be trusting at first, but even if it's just a small rapport to help them come back again, right? Then it's just that small steps. I think stepping away from an agenda and really trying to just engage them where they're at and meet them where they're at and be really excited that they're there and not not hold those no-shows against them, not count that, not taking it personally. And I think, too, as a mental health provider, like, I'm really privileged that I don't have to deal with productivity. So those no-shows don't impact me professionally either, right? So I don't have to worry about that piece, where I think we see this with, like, our PCPs, where they have productivity quotas that they have to meet. And so if our patients no-show them, then they get, nope, I'm not going to see this person anymore. So that can get in the way.
So more of a comment, not a question. Robin Sir stated that they agree. We need to let the patient drive their care and decide what type of appointment they want. We want to open up doors again and start seeing people. And as a follow-up to that statement, also, they work at a FQHC, and they have never shut their doors. They have found a way to do it safely and continue to do it and make improvements. Some other comments. Our clinic has found telehealth less intimidating and more accessible than coming to the health center, so it can be empowering for some. So I don't know if either of our speakers have any thoughts on that.
Definitely agree with that. I think for some people it's great. Yeah. It's just a matter of, for the others. I think one concern that I've had throughout this whole period of time is I feel like some of my patients have just kind of disappeared, and I'm really worried about those people. And I do think there's a part of me as a provider where I just feel better when I am able to see someone. I think there's probably a role for, I think for some people doing most of their visits by telehealth, but then sometimes you feel like you just can't quite figure out what's going on through a phone call, and so seeing them in person occasionally is helpful. So I think if you have the capacity to be flexible, it's nice to be able to do that. But yeah, I agree. I mean, there are a lot of benefits to telehealth. I know I personally, I love being able to do that now. It's so much easier as a patient. So.
Yeah, I agree. I think that it's awesome that it's empowering to some, and that's fabulous. And as mentioned in my bio, I'm trained in EMDR, and there's even a platform for us to do EMDR through telehealth, which has just been really incredible. So, and that some people have really, really benefited from doing EMDR like telehealth as opposed to in person. And patients that were hesitant to connect with me because New Hampshire is so rural, and I actually travel across the state every week, but I still can't capture all of my patients. Some of them still live like an hour away to even come to see me, despite me traveling hours throughout the week. That it's really opened the door for me to connect with people in a way that they hadn't ever really thought about connecting before. So I think that there's so much value, and I'm all about meeting the patient where they're at. So if that's what's good for them, then that's what matters.
And we have one final question in the chat box. Many clinics do not have behavioral health specialists on site. How can PCPs become more comfortable providing behavioral health care at the basic level, if possible, to prevent suicide or overdose?
I think that one of the things, it's interesting, actually another AAPC presentation about suicide that I did, I spoke about this specifically because I think that there are certain questions that PCPs and medical providers who aren't necessarily behavioral health specialists can be trained in to ask and assess and then be able to make appropriate referrals. So I think that there's kind of this this educational piece that needs to happen with current PCPs, but again, I think there's also another piece about starting in med school, talking with med students about suicide and substance use and normalizing it and not making it this really scary, I can't talk about this, I don't know what I'm going to do if they say yes, they're suicidal. But normalizing it in the sense of people have suicidal thoughts and they're trusting you right now to say that they do that, and that's a big deal. So really honoring that, and then how do I help this person, which again can be so powerful for a patient to say, yeah, I'm feeling suicidal, and then the provider to respond in a way that's so compassionate and is like, I want you to exist still. I want you to be here tomorrow. You know, that can be really powerful for those patients. So I think that there's an educational piece that's really, really powerful, and it doesn't, it's a low-hanging fruit, right? Like, it doesn't have to be really intensive. I know, at least here in New Hampshire, and being from California, often my experience in California as well, from the Bay Area, so the social workers are often included in that PCP group, that multidisciplinary team. So the social worker might be a really great resource for that around training. And if they're not comfortable, I think that there's definitely different individuals like myself who are happy to provide training to those docs that want to engage in that kind of care and paradigm shift.
Excellent. Thank you so much, Dr. Mears. So with that said, we just want to thank everyone for, first of all, I want to thank our speakers today, Dr. Jocelyn James and Dr. Erin Mears, for representing your ATC, the Mountain West ATC and the New England ATC, and for sharing this excellent information with us. Thank you all who have joined us and participated. The recording and these slides will be available on the ATC NCRC website within a week as a resource. Please check out the website also for the 2 remaining sessions in this webinar series and to view the recordings from the previous sessions. If you have any questions, please feel free to contact me. Thank you and have a great day.
Thank you so much.